Hello, friends. Welcome to this episode of My Mentor. This is the place where driven, visionary, and ambitious leaders, entrepreneurs, and professionals meet. Today, our special guest is Dr. Nkuli. She's a medical doctor and she's the CEO of the Nelson Mandela Children's Hospital. Dr. Nkuli, welcome.
Thank you. Thanks for having me.
Should I call it Dr. Nkuli? Should I call it Nkuli Lego? Should I call it? Which one do you prefer?
Nkuli is fine.
Nkuli is fine. Are you sure? You started so hard for this
okay,
doctor.
You can call me Dr. Nkuli. I know
Yeah?
if my mom sees this, she'll be like, they should have called you Dr.
Exactly.
Nkuli.
I'll
For
go
her.
with Dr. Nkuli.
For her.
Absolutely. You are a medical doctor, of course. What drove that passion to become a doctor?
Sure. It's a very long story. So when I was about 9 years old, I was in an accident, a bomb blast accident in downtown Johannesburg.
Seriously?
Yeah. It was during the time of the transition when we were moving from apartheid to a democratic South Africa.
Yeah.
Now you know how old I am. Anyway, I was around 9 years old at the time, and there was a bomb blast in downtown Johannesburg.
Sure.
And I was the only child out of a few people who were injured during that incident. And I was taken to hospital. It was Hillbrow Hospital back then. And in that moment, I think that's when I decided, oh no, I think I want to be a doctor to help children who are injured or sick like me. And a few years later, I then developed a cancer. I had ovarian cancer at the age of 14. And of course, you know, with cancer, you spend a lot of time in and out of hospitals. And so for me, that entire experience sort of endeared me towards medicine. I always knew I wanted to help people, not necessarily knowing how.
Yeah.
And so those experiences as a child then sort of pushed me towards a career in medicine, and specifically, hopefully, to work with children in some way or the other. And that's why I became a doctor.
Wow, that's amazing.
Yeah.
And you never considered any other career paths?
Well, not really. I think I'm just one of those people. If I set my eyes on something, that's exactly what I want, and I'm not willing to compromise. Even though along the way, as you know, you get you deviate, things don't always work out the way you do. You want them to. I had applied when I finished matric. Actually, I applied for law. And I applied to do architecture. So it was the three. I was like, it's either medicine, law, architecture.
Yes.
Architecture for my love of art and beautiful buildings.
Yeah.
And law because I'm an advocate, I think, by nature, you know, and I want justice and I want the right things to be done. So those were my three options. But I always knew that I have to do medicine. And in fact, my road to medicine was not as clear cut because I didn't get in the first time. I had to deviate and do physiotherapy. And that's primarily, I was an A student all along, good marks, A, Bs. And when I got sick with cancer, it sort of affects you, how your cognitive ability and just being in and out of hospital, you're focusing more on your health than on studies. And so when I was in grade 9, then my grades really, they tanked. And so I knew that, okay, getting out of matric, it's not going to be as easy as I thought it would be. And so I started with physio, and after 2 years, I thought, no way, I still want to do medicine. Physio is just not it. And after a long battle to try and get in, and my grades had improved because I'd had to learn that it's no longer about being smart, because I was a smart kid.
Yeah.
But I knew now that, okay, my smarts have to be coupled with hard work. And so getting into varsity, I sort of pushed the hard work more than just relying on God's gift to me, which is a brain that works. And so I had to learn to work hard, and my grades improved, and I finally managed to get into medicine in third year. And so that was my very interesting journey into medicine. Yeah.
That's an amazing journey and story of resilience. The sickness at 14 and having to go through that period and still keep this prize of wanting to be a doctor intact and alive. That's quite amazing. Did you find that was innate, or was it the support structure you had? What was the cause?
I think it's a combination of both, because I don't believe a person makes themselves.
Mm-hmm.
A person is brought up in a village, and the village makes the person. So there's an element that is innate in you. You want certain things, but you need a support structure to get to where you want to go. I don't think people can truly say, I made it on my own. And I'm certainly not a person who can say, I made this a dream happen on my own. And so I had a huge support structure from my mom, my aunts. And I remember even my mom saying, when I was finding it difficult to get into med school, maybe you should go overseas, because my aunt was overseas at the time, and go to like a university elsewhere, So I had that support structure and people who understood what I need and what I wanted and the dream that I had. And so my passion was really supported by those individuals. It was there, but I had the support structure just to keep me going, because without them, really, I don't think I would have made it.
That's very true. I mean, a lot of people play a huge part in helping us get to where we eventually get to. As far as your studies are concerned, you studied at Wits, so that's where you did your medical degree.
Yeah. I'm a Witsi. It's so unfortunate. I'm a Witsi undergrad, postgrad. I'm like,
Everything.
you guys, I need
Lecturing
to, I'm like, I need to go study somewhere else and just get a different experience. But it just happened to be that way. I always tell people I've lived my life around Parktown. I went to primary school, high school in the Parktown area, varsity.
Wow.
Yeah, I went to the German school. So it's just in the same vicinity I've lived all my life. I'm like, no, I think the next 10 years I must find a different city to live in. Yeah.
But what made the Wits stand out for you to take
honestly,
that as your...
Wits did not stand out for me.
Okay.
I'm from Soweto.
All right.
Yes, born and raised in Soweto.
Okay.
The child of a single mom, only child of a single mom.
Okay.
And so when I graduated, my mom said, you're going nowhere. Find a university close to home.
Wow.
I wanted to go to UCT. All my friends were going.
You missed out, but it's fine.
I know. And I remember first year, second year, every holiday I used to go down to Cape Town.
Is it?
Yeah. I'm like, no, I need to at least have a pseudo experience of UCT. But it was really my mom. And my aunt went there. My dad graduated from Wits. And so it was like, it's a good university. It's close to home. Just go there. That's how I chose it. I didn't choose it.
And even post-grad, you still had no say.
No.
Now I can.
No, post-grad.
It was your own doing.
Post-grad it was my own doing. By the time I got to post-grad, I got a position because I specialize in what's called public health.
Okay.
And so it's all about getting the post. I'd applied to Red Cross, but I didn't get a registrar post at the time. Okay. And I got it at Wits. And I was like, okay, then I'm meant to be at Wits. And I stayed and I chose Wits.
And the journey to becoming a medical doctor is quite a special one. By the way, I did medicine for 1 year.
You did,
and realized I'm not sure if I'll work well with blood, and also I pivoted completely something different. But I have huge respect for medical doctors. Yeah. I mean, you study for 6 years and then you have to go do what's it called? Is it
registrar time? When you specialize.
And 2 years, don't you do ComServe or something like that?
So you do ComServe, you do internship, then you specialize for 4 to 5 years.
Yes. And that time when you were doing ComServe, can you just take us there? Like what was it like for you?
Wow.
Was it what you expected, or was it a total shock?
It was a shock. Oh my goodness, yeah. So medical school, it's fantastic, but I remember thinking first year, I think the world would have ended by the time I finished, because 6 years, when you're like 18, 19, 6 years looks like forever.
Too long,
So I thought I'd be dead. And okay, fine. Then we got to 2005, 6 years had passed, we finished. And then you get into internship, you work hard. You are constantly working. We used to do 36-hour shifts.
Sure.
You work 24 hours, then you work the following day until 12, then you can go home.
Sure.
Internship was better in a sense that you work in an environment where you're almost protected. So you have seniors who are there. When you get into ComServe, where you're in a rural area, you have limited resources. It becomes, I think that experience of rural, semi-rural, under-resourced hospitals is what made me pivot from clinical bedside medicine and do public health and want to go into hospital administration.
Okay.
Because I had experiences where the nurse matron would be like, no, this nurse can't help you as a doctor. They haven't trained to suture patients. And I'm like, but they can help. I can't be the only doctor in casualty and there are 15 patients waiting to see me and they have different things. And there's a nurse who is more experienced than me who can assist. And you'll find a lot of us, you'll hear a lot of doctors say the people who train you are the nurses on the ground. And you'd have a nurse matron, no, don't help this doctor. And you don't have this, you have to borrow it to another hospital. Sure. I was like, guys, we need people who have been at the coalface, at the front lines to be leading healthcare in this country. You can't have somebody who does not understand what it means when I say, but I need this item or that item urgently and thinks I can wait for tomorrow. I'm like, you need people who understand the industry. And if they don't understand the industry, at the very least, they need to have compassion.
Yes.
And what I found working in some of these hospitals that you just didn't have that. And things were falling apart, and I refuse to work in a system that's falling apart and not at least try and do something about it. So it's really those formative years in my career that shaped my thinking and what I want to do in healthcare and the difference that I want to make. Because I don't want to be a victim of my circumstance when I can do something about it. And a lot of us, I think, as medics feel like we're victims, even though these days, doctors are speaking out. I'm seeing their petitions there, which is good. We must use our voice and not just be, let's look at the patients. It's for the patients, even when we raise our voices about the conditions that we work in. Yeah.
That's very interesting. You mentioned ComServe and internship. What's the difference between the two?
Oh, so internship, you just finish medical school, so you work under supervision. So you're not registered yet as an independent medical practitioner. Whereas ComServe, they added it, you are now an independent practitioner, you can work on your own. And it's really meant to serve underserviced areas in the country. So that's when they throw you in some rural hospital, wherever.
And how long are those two?
They used to be a year each when I graduated. Now it's 2 years internship and 1 year ComServe.
So 3 years in total.
3 years. Now I'm hearing they're going to add another year to ComServe. I'm like, nobody's going to want to be a doctor anymore.
And you don't have a choice to say, I can't do this. It's part of the training.
It's part of the training. Otherwise, you won't be registered as a doctor in this country. You'll have a degree, but you won't be able to practice.
Wow.
Yeah, so you have to do it, unfortunately. But look, it's good because medical school teaches you theory. And internship and ComServe teach you the practical stuff. And medicine is all about experience. With us, it's not about what you learn in a book. Because a patient will humble you. Ne? They'll come, they won't look like the textbook. They'll look like something else. So you need the experience. Yeah.
And when you're done now with ComServe, you've got different options, I imagine. You can you go specialize immediately, or you need to go?
No, you can. You can. Nowadays, it takes long because to get into a training program to specialize, there's now waiting lists.
Is it?
Yeah. A lot of doctors now want to specialize. We used to have a lot of GPs previously, so people would just finish, go and practice, open the shop.
Yeah.
But now I think the competition is just so much that for GPs, and it's no longer lucrative to be in medicine. And a lot of our patients, you'll find with information being available, that a parent will say, no, I want a pediatrician. I don't want a GP. I want a pediatrician. I want a surgeon. Because now our patients are more educated, so they don't want to via the GP at the corner there. So the GPs are, it's more difficult to run a family practice. And medicine, I don't know, maybe like other professions, there's a lot of hierarchy. And so if you're a GP, you're over here, so you must be a specialist and people will take you seriously. Even though the GPs, I think for me, they have to know everything, right?
Yes,
they need to know how to channel you. I'm like, you need to respect those guys, because those are the guys that pick up the problem to send to you. If they don't get it right, that's how we miss problems. That's medicine. And everyone wants to specialize now because you can make more money.
Yeah.
If you're a specialist than a GP, medical aids don't reimburse you the same. Specialists and more than GPs, even in the public sector. So people want prestige.
And how long is that specialization program for?
It depends. They differ, but on average it's minimum 4 years.
Wow.
Minimum.
And so you study for 6 years, you do 3 years ComServe plus internship. And then you say, okay, I'm going to go specialize another 4 years minimum.
Mm.
During those specialization, that specialization time, are you working on the side or like?
Yeah, I know you're working. You're
Okay.
working. No, so after you finish med school, you're working, you're earning a salary.
All right.
Oh, and that salary goes
Is
goes
it?
up. Yo. It goes up.
Okay.
I'm telling you, more than us. I think my first salary was like 8,000 rands.
Okay.
Nowadays, these guys are earning 40 when they
Is
start.
it?
Yeah, it's us. We're 8,000. You know, we're using taxis for like a year. We're using taxis.
Don't
for
worry, I
years.
used taxis also when I started working. So.
Yeah, no, we're using these kids these days, they drive fancier cars than us, you know. So you're working, you're earning a salary, just that you're working very, very hard and long hours and at night and but you're earning a salary.
So this backlog or waiting list, does that mean there's not sufficient space?
Yeah, there's not sufficient posts. So because the government is the only sector that can train.
Okay.
You can't train in the public sector. They're not allowed to train doctors. So you can only train in South Africa in a public hospital.
All right.
And because there are constraints in funding. So you can be trained if you're willing not to be paid.
All right.
And who wants that, right? So, but because there's not enough money for enough posts, that's why now there's a waiting list. So you can wait 2 years to get into a program to specialize because the posts are just not available.
And how do people feel? How do the doctors feel about that? I mean,
or
is it just an accepted norm now?
No, it's an accepted norm. It's been going on for so long. I think after us, probably 2 years after us, this was, when did I qualify? 12 years ago when I finished. I finished my specialization 10 years ago.
Yes.
So I think at that point, things started shifting and the waiting list started growing. And so people are just used to it, that you have to work at least 2 more years, 3 more years before you can specialize.
And this is a funding problem. Is this the source?
It's a funding problem. It's a funding problem. If you can say, I'll pay for myself.
Yeah.
I've got a rich family I come from. I have a sponsor. Then you can be trained. Because we have a lot of guys who come from other countries, Eritrea, Somalia, we call them supernumeraries. Okay. And their governments pay for them to come and train in South Africa. So if you have money, you can be trained. But if you're waiting to get a position to be hired so that you can train, then it takes time.
And why do we have a funding problem? Is it an issue of mismanagement or growing demand? But
who's gonna see this program? Look, it's 2 ways. There's a growing demand for our services in this country. You know that it's about 80% of the population is reliant on the public sector.
Yes.
And 20%, I think now it's even grown less. 16% of people are insured in this country. And so a lot of money is going into providing the service itself. And so government just does not have enough money to cater for the population that we have right now. And we have a lot of migration within the country, people coming into the country, which I think are then not accounted for in the census, right? Because how budgets are divided with treasuries based on the population numbers. That's how we get. And so if you've got populations that are not counted that you don't know, then you're going to be underfunded for the services that you provide. So that's really the main issue. I don't think it's so much that, there are issues we've seen on the news. There are issues. But I think we're just chronically underfunded in health because we have so many people that are unaccounted for that we have to treat. And when you're in a hospital, we cannot concern ourselves too much about where you're from, how you meant to be here. We treat the patient in front of us, right? And so that's really the issue in health, that we're just chronically underfunded. I think the fiscus is stretched in general for many programs and not just health programs.
If my memory serves me well, I seem to recall a few years back, there used to be this narrative that we have a shortage of doctors. Does that still exist? Because it's counterintuitive.
Yes and no. No, yes and no. So you're right. We have a shortage of doctors, but we don't have money to pay for the doctors that we need. So we know we need the people, but we just can't afford them because we don't have money to pay them. And we even increased our production now of medical doctors in the country. I know at Vets, when I was studying, I think maximum, when you are many, you were 200, then you had too many students. Now I think they have 300 graduating final year students. But when you look on the flip side, there are no posts to employ everyone. And these days I was shocked. I was like, gosh, a doctor has no job. Like, when did that happen?
It's unthinkable.
It's unthinkable, but it happens. And we're like, when we're in the hospital, we're like, I need these people. Right now I'm like, I need the doctors, but I have to look at, do I have money to employ them?
Yes.
So they're there and we need them. And they're still few, but we just can't afford to employ them like we have been able to previously.
Wow.
Yeah.
And you specialized in public health. What's public health about? Cardiology is something to do with the heart.
Yes. Public health is more, it's like population health or global health. You know, with COVID pandemic, I like COVID for that because finally people were able to understand what public health is about.
Yeah.
It's really looking at diseases that can impact a whole population and how do you prevent, how do you prevent an individual from getting ill or a whole population from getting better?
Yes. Yeah.
And so that's what we concern ourselves about. That it's not just about the individual.
Yeah.
What interventions can we put in place that will be cost effective, that can impact a lot of people and keep the population healthy? And a typical example of a public health intervention was the ban on smoking, indoor smoking that was introduced. And so that type of thing, fewer people will get lung cancer because now there's less exposure to smoking inside buildings. People are now smoking outside. The sugar tax, even though we don't like our Coke, that doesn't taste so nice anymore. So that's a public health intervention, basically saying, too much sugar causes obesity. Obesity is a problem because of this and that. So that's really what it is. It's more like prevention of illness, because by the time you get to hospital, it's almost too late. It's too late. You need to catch people in their communities before they get ill. Prevent them from getting ill, and if they get ill, catch it early, and that's what I guess Discovery, I'm not promoting Discovery, but the Vitality program, things like that are what you're keeping people healthy. That's what public health is all about, catching the cancer patients early. Now we're seeing a lot of young people who have cancer. So we are saying, what programs can you put in place to catch them early or to prevent people from getting cancer? So that's really public health.
Interesting. That point you mentioned about seeing young people now catching cancer. I presume when you look historically far back, that phenomenon wasn't, as it is now. What drives that? Does it have anything to do with global warming?
Who knows? Because cancer is really it's multiple factors, and it depends what cancer you have. Some of them require you to have a certain virus in your system, like cervical cancer, breast cancer. There's a genetic predisposition to it. So I think with things are changing, evolving as humans, we're also living longer. We're getting exposure to different carcinogens. And so that's probably what's contributing to it. And I'm sure somebody's studying it somewhere to find out why. You're seeing a lot of young women with stage 4 breast cancer, whereas before you used to tell people, no, do a mammogram once every however many years. Now you're like, every year check yourself out, even if you are 30 something. Don't wait till you're over 40, because before you're like, no, when you're over 40 check, but now you have to check. I saw a young celebrity lady, I think she was on Real Housewives of Johannesburg, who passed away last year from stage 4 breast cancer, and she had just turned 30. So it's a real it's an issue.
Most people, when they think or see or hear of hospital, they think doctors, nurses, patients. We forget these are organizations that need to be led, and we'll have a CEO such as yourself. It's obviously quite unique to have a medical doctor being a CEO. It's not in our face, but it's there. But it's not something we come across on a day-to-day basis, because when we go to the hospital, we deal with the doctors as practitioners and not the CEO. So as a CEO of a hospital, what do you do?
What don't I do? So look, I guess a CEO, for me, I'm one of a CEO is a CEO. The principles are the same, right? You need to lead the organization, make sure that you have adequate resources to be able to make a success of the organization, identify opportunities of growth, especially in an organization like ours, which is relatively new. Where can we grow? And not just grow, how can we make sure that the product we're putting into the market, right? Because that's how you need to see health services. Yes, we're helping people.
Yeah.
But what is the product that you're putting out there?
Yeah.
What is the value proposition that you're putting out there on the market? And because we're in an area where there are lots of hospitals, we also had to make sure, how do we stand out? Yes, we're a beautiful building.
Yes.
Beautiful building, you must see it.
Yeah.
The infrastructure is excellent, it's new, but so what? I mean, a building doesn't treat a patient.
Yeah.
So what are we bringing to the market that people can say, I want to go to that hospital. I don't want to go to X and Y around the corner or closer, but that one. And so as a leader of the organization, you also have to care about those things and make sure that you keep that the quality of that product must be of a certain standard, and everybody understands that this is what we need to produce as an organization. And it's very interesting that when you're in a hospital, it's difficult to get people to see that. You sort of have to get this mind shift change that, guys, yes, we're providing us, it's a service that you're giving to people, and it has to be an excellent service. And worse with us, it's a life or death service, right? With us, if our product is defective,
absolutely,
it's life ending, it's life changing for families. So we have to be extra clear on what we are doing and what we're bringing to families. So that's really my everyday job. And of course, because we're a service industry, the people that I work with, the staff members, are second to patients. Sometimes I always say, maybe you are first to patients, because if you are not able to do your job well, you're not happy at work, the work that you produce, the product that we produce, which is really reliant on you, will not be a good one, and our patients are not going to have an experience. So it's really caring about the people that I work with.
Okay.
And taking care of the staff that we work with. And and we've seen with COVID, we were hardest hit as the healthcare sector. Well, not necessarily as a children's hospital, but as the sector, you know? And so just leading and taking care of my team, I realized that that's one of the most important things that you need to do. It's about the work, but it's about people, and people are not just people who come and do, they are whole, they have families, they've got, you know, and to be able to see them as that and not just as factors of production in the hospital. So that's really my job and what I love about my job. And then of course there's the finance part and you know, and the accountability and the governance part, which is something that you have to do and make sure that we stay afloat as an organization. And so, but and being a medic in a CEO job was interesting. It was a mind shift change for me as well. You know, just to make people realize, people always say, no, money is not important. You know, that's what we say, doctors. Money is not important. It's the life of a patient. And that's true, because that's what we are taught and that's our jobs. But just to also accept that without that funding, then we're not going to have a hospital. You can't save those patients. And if you don't use our resources the way we should, then we won't save the patients, you know. So just trying to drive that narrative that our thing, we are saving lives. And to save those lives, these are the things that we require. But I try not to keep it their problem, it's my problem. And their problem should be taken care of. Taking care of patients.
Your reference to COVID and how it impacted the health care sector, it just brings memories about the times where we're still in lockdown 5 and doctors had to go to hospitals and nurses. And take us back there, like, how did you approach that? What was happening? The fears.
I know. I'm like, I think we should write a book about that. My goodness. I remember, was it the 27th of March when we were on lockdown? And I had to go to work the next day. I wasn't even sure. I think a lot of guys were like, should we come to work? I'm like, guys, we have to come to work. And the admin guys were like, but we're not seeing patients, so we don't have to go to work. So I said the admin guys can stay at home. But for me and the leadership team, I was like, you need to lead from the front. You have to be at work whether you're in your office working, but the fact that you're running a 24-hour service and now people have to come to work, I have to go to work and I have to make sure that they're fine, that because they're just as scared as I am, you know. And when we drove out, it was the scariest thing. There was like nobody on the road.
Yeah.
There's nobody. And I live in Joburg in the north. There's an intersection. Is it near Megawatt Park and Woodmead? You know, it's very busy in the morning. Very busy. And those days there was nothing. You know, you get to the intersection and you're like, should I stop? Should I go? Where's everybody? It was very, very scary. And so a lot of people were worried about their families. You know, why do I have to come to work? I'm like, but you have to take care of these patients, you know? And so our job really was to take care of them. I remember there was issues of when the masks were still a thing. Before the cloth mask issue was introduced, people were now stealing masks. Sure. You know, they had to take some, and you catch some of the staff with masks in their car because they want to take them to their families, you know, and mask was like a thing. It was selling at such high prices. You buy a mask that you used to buy for 50 cents. Now it's 5 rand. Hand sanitizers. Wow. You go to the shop, there's no hand sanitizer. You ask suppliers, no, their markups were ridiculous.
Yeah, I remember very well.
You remember? It was ridiculous. And the staff was so scared. I remember I even had to take the mask. There's the N95s. I don't know if you know the N95s. I had to take it to a lab in Cape Town because they were like, no. Is this the genuine one? Is it going to protect us? We had to take it to a lab at UCT in Cape Town to make sure that the product that we buy can filter. And because everybody was like, they don't want to catch COVID. And once the first staff member passed away from COVID, the hysteria then, you know, it just gets so ridiculous. People don't want to come to work anymore because they're worried. I remember one time, because I like doing my walk around the hospital just to see what's happening. I think they thought they're like, no, come and see. Yeah, would you work near this patient? And I had to cloak up. I'm like, no, I would work. I was scared, but I was like, I had to show them that if I'm expecting them to be there, then I should not be afraid to put on the PPE and also be next to that patient and help them, just to give them some comfort that we bought you quality PPE, but you also have to be careful of COVID outside of the hospital. It's not just the hospital. But there was a lot of drama and hysteria. But I think losing the colleagues and some of the medical staff, it was,
It was a season of, I guess, especially in a case like yours, as a leader in a hospital, which is where chances of finding someone with COVID there are very, very high. Yeah. And you've got staff that feel like, you know, we're not sure if we're comfortable working here. You have to provide that leadership. How did you keep your team motivated, if at all, or at least be willing to still continue and soldier on? It's a big ask.
It's a big ask. It's a big ask. And our hospital, interestingly, as COVID was happening, our hospital went through a transition. So I've only been the CEO there for like 18 months now. Yeah. My boss quit.
Is it?
The CEO quit. Oh, and the CFO quit. Oh, we were traumatized. So it was COVID. It was this management change. It was just chaotic during that time. And for me, I remember when the board first said, no, she will take over for a little while they find a suitable replacement. People were uncertain. How do we know she can? And yet I had been there for a long. How do we know? But I understood their angst and their anxiety because this is too much. It's like, it's COVID. Now it's this leadership change. Now it's this Nkuli that we've been working with. How do we even know she can lead the organization? So when I started, I was scared, right? I was scared. I was stressed. I was like, what in the world am I thinking? Yeah. You know, why did I even accept this acting position? What do I know? Yeah. But at that moment, I felt, look, I've been here. I understand the environment. I understand the people. And the last thing you want is to bring a completely new face that people don't know. So let me take on that responsibility. Yeah. And I told myself that one thing, and I told the team, I had a whole staff meeting when I started. The whole 300 staff, whoever wanted to join would join. Just for people to know my thinking and where I'd like to see the organization, and at least give them a glimpse of who I am. Because I'm by nature a quiet person. I mind my own business. I do my thing. So people didn't really know me. So I thought, let me bring them into my confidence. Let them know who I am. Yeah. And I opened the lines of communication. I said I'll be very open, and I think doing that made people feel a little bit more comfortable, like they know. And I shared what are the issues in the hospital, what do we need to do, here's the truth about this and the other. And so during that transition and having that transparency with people, I think that's what then made people a little less anxious, because at least they had information.
Yeah.
And I was truthful, because I believe in being honest, with people. And so I was truthful about a lot of things. Obviously, you filter what you tell people, what you don't, because you don't want to create a crisis and people are running amok. But to be as truthful, as honest as I possibly can. What I cannot do, I cannot do. And I cannot promise you the world and deliver something I cannot. That's just how I am. And so, and whatever I promised I would do, I did. And I made sure that I identified what are the low-hanging fruits, what are the things that if people can see this happening, then they'll have confidence in our ability to manage as a new team. Because then we had to bring in a new CFO who was new to the organization. So 2 big positions being vacated in any organization is destabilizing. Yeah. And so we just had to do that. And I think just having those small wins along the way sort of changed the mood in the hospital. It's not perfect yet, but we are standing, we are there, and the fact that we are there and we're standing, and a lot of people kept saying, "Oh no, you're closing. This was in May last. Oh no, by October you'll be closed." That's what I was hearing. Oh no, Nkuli's a nice girl, but she doesn't know what she's doing. All of those things, and it's that criticism that fueled my determination to make sure that it succeeds, because I hate failing. I absolutely hate failing. And so I thought, no, I'm glad they're saying all of this. Then it pushes me to work even harder and make sure that the hospital succeeds. And thank goodness we are here a year later. We haven't closed our doors, and we're not planning to close the doors of the hospital.
That's really, really amazing. So the Nelson Mandela Children's Hospital, you said it's 5 years old now?
5 years old, yes.
How did it come to be called Nelson Mandela Children's Hospital? Is there any link?
Oh yeah, direct link.
Okay.
I always tell people, I think this is the one thing that Mandela is linked to directly.
Yes.
And so he had the Nelson Mandela Children's Fund, right? Which he started with his own money. Yeah. So that fund is the one that built the hospital as a legacy project for Mr. Mandela.
Yes.
And so when one of his former employees at the fund, she became later the CEO, her child got injured in a fire in their house, and unfortunately eventually passed away. I think he was 5 years old, Ulindo Guhle Mkabela. And so he was admitted at the time to one of the Joburg hospitals in an ICU, and Mr. Mandela went to go see him, and he was surprised to see a child in a bed with adults. And he asked apparently at the time, so why isn't there a facility just for children? That even if it's an ICU, there must be other children around.
Yes.
And so then they decided at that point that maybe they should build a hospital as part of sort of his lasting legacy. And that's how it came about. So it's literally really from his initial project, which is the Children's Fund, and then the hospital came about.
Amazing. And is it a private hospital? Is it a hybrid? Is it a public hospital?
Hey, it's a hybrid. It's a thing that doesn't exist. Everybody keeps saying that. Oh my gosh. I think that's what makes the hospital complex. It's an NPO.
Okay.
It's an NPO, so we are a charity organization. Government gives us a grant. To take care of public patients. And then, but the grant doesn't cover the full budget of running the service. We have to raise funds ourselves. And so to raise those funds, we get donations, go to different corporates for support. But we also run a private service. So really the main aim of our private service is to subsidize so that we can keep the hospital going. So we're like a hybrid. So I'm and to be a private hospital, public hospital, NGO, there are different regulations that apply.
Is it?
Oh my goodness. So I must remember, okay, what am I dealing with today? Okay, today is private hospital. So it's different rules that apply from a legislature. It's very complex, but it's interesting.
Yeah. And your decision to work at the Nelson Mandela Children's Hospital, how did that come about? You could have gone anywhere else, right?
I could have. I was actually working at Charlotte Maxeke
Okay.
across the road, so it's across the road. And I didn't, to be honest, I didn't even know there was a hospital being built across the road. When I was working at Charlotte. So in 2000, sometime before I finished medical school, I think I was in 5th year, I had a 15-year plan. So my 15-year plan was, the usual internship concept. Then I specialized. So I wanted to do pediatric surgery. That was my initial plan. I do pediatric surgery for 6 years. It was going to take me another 6 years to do that. And then at the end of that, I wanted to open a hospital, a children's hospital in Johannesburg, the first children's. That was my 15-year plan.
Wow.
And then somewhere along the way, I decided, no, man, to open a hospital, I don't need to be a pediatric surgeon. There are different skill set that I need to acquire. And so public health actually helped me with that. And so I've always wanted, it was supposed to be my own. I've always wanted a pediatric hospital in Johannesburg because of my experiences as a child. I thought it would be, as much as you're a sick child, it's better to be a sick child in a kid's hospital where you see other sick children. And so when I heard the hospital was being built, and I was at Charlotte as a manager there already, and a lot of my guys in pediatrics were moving and leaving us at Charlotte. And I became curious, like, where are you all going? And I asked one of them to invite me to just have a look at what's happening in this hospital. And when I saw the facilities, I was thinking, this is to be a good facility, because I was struggling at Charlotte with beds all the time. I'd have children sitting on chairs. I'd have pregnant women waiting for 4 hours, some a day in casualty because they couldn't get a bed. I was always struggling for beds, and I just felt, but this hospital across the road can help with the problems I have at Charlotte. And so when the position came, I thought, okay, let me go across. So if I go across there, I would understand what are the problems and the needs, and would and try and make sure that this hospital helps the other hospitals in the area. And that's really why I jumped across to Nelson Mandela.
What's the age cap for someone to be admitted in a children's hospital? So a kid, you are a kid until you are what age?
You're a kid until the law says you're not a kid, and that's debatable. You must ask the pediatricians. They fight about it all the time. It used to be a fight. Some say, no, it's 14, it's 16, but our age is 18, because by law, age of majority is 18. And so our cap is 18, even though we've got older kids older than 18. Because sick children, they don't grow, so they look tiny. But officially it's 18. But some of our chronic patients we keep. I used to attend my cancer clinic until I was 22.
Is it?
You get attached, because these kids, they are there with the same doctors. You don't want to be transferred to other doctors. So, but 18 is our official age cutoff.
And does the hospital focus on specific types of sicknesses, or is it general?
So right now, it's specific types of illnesses. So your specialist stuff, neurosurgical, heart problems, general pediatric surgery. So we're more leaned towards surgical disciplines. We've got a huge surgical unit. And the reason they have that is because we know in the public sector, we struggle a lot with surgical and surgical lists. And so a lot of our services are really geared towards surgery. If you need surgery, we are there. We're opening an orthopedic surgery unit. And so surgery covered, and then dialysis, kids with kidney problems as well, and a huge ICU complex which supports the general surgeons.
Okay, fantastic. And of course, you're also a lecturer at Wits.
I am doing too many things. So lecturing, I believe that people should impart knowledge.
Yes.
The knowledge that I have is not for myself, but it's to the benefit of my community and others. And that's why I lecture at Wits. And just to keep you on top of your game, because when you're teaching students, they'll ask you questions and you're like,
never thought of that.
I never thought of that. I must go and read. And so lecturing for me is just that thing, just to keep my mind sharp and to think about other things and to impart knowledge. I think you shouldn't hide information. Information must be shared.
And which course do you lecture?
I do. So we have undergraduate medical students who do public health. So public health is part of the curriculum.
All right.
So I do a lot of the sort of final year teaching and exams. And also I do, what do you call it? to review master's students' research protocols. And so I also do that. I really want to prefer to do postgraduates, but it's good to shape young minds at undergraduate level. Yeah.
And of course, given you are a CEO at the hospital, I presume you don't practice medicine now.
No.
Don't you miss it?
Everybody asks me that. I used to miss it, to be honest, until I became the CEO.
Okay.
Then it's very interesting, this thing of being a CEO and understanding how things work, you know, and you just don't have time. And I realized that the administrative role is important. Without a strong, and I always tell my team, I'm building a formidable administration. I cannot have a weak administration leading specialists who've trained for years, who are top of their field, but you don't have a formidable administration, because that will fall apart.
Yeah.
And so for me, it's been such a growth professionally, personally, and so I don't miss medicine because I don't feel like I'm out of medicine. I'm away from
just
the
a
bedside,
different role.
But just a different role, and an important role for supporting what I love, which is the patient. So at the center of everything I do, wherever I am, there's a patient.
Brilliant. As we wrap up, I'd like to get your insights, or at least some advice for maybe a medical student who's finishing varsity now, or someone who's just started doing ComServe or internship and is looking at this journey feeling, I'm not so motivated anymore. What words of advice or wisdom would you give to someone like that?
So I always say to people that, you know, it looks hard. It looks hard. But once you achieve the thing that you want to achieve, it's not so hard anymore. There's a saying that we like at the hospital, at Mandela used to say that it always seems impossible until it's done. Things look difficult, but until you'll get there. You'll get there. And always remember why you're doing what you're doing. Because that's what keeps me going all the time. Even when things, it looks like, oh, it's so far away, I'll never reach wherever I want to. I always used to remember, why did I do it? If your why was wrong, it's going to be difficult. But if your why is really your true north, then it will keep you going. So to them, stick to your passion and don't be, you know, there's this thing now, we like shaming people for changing and pivoting and doing something different. You're allowed to change. As life, we always say life is short. Yes, it's short, but life is long, you know. You're allowed to change direction. If you felt like, oh, I want to be a surgeon, no, but now I want to be something else. Do whatever you're passionate about and what makes you happy. You don't want to be unhappy. You spend most of your life at work, so you don't want to do something that you don't like. You know, find that thing within medicine. Medicine is broad these days, very broad, you know, and so we shouldn't be caged in by this hierarchy that exists in medicine. Do the thing that you want to do and you're passionate about.
Okay, brilliant. My last question, what's your next big chapter?
Oh, I asked myself that question a few months ago. I was like, okay, you know, after you turn 40, life changes a bit. And I was like, you know, I've always been forward looking 10 years from now. I have it at the back of my mind where I want to be.
Yes.
Like I want to do something multinational, something big. But then I realized that I have to be in the moment. I have to be present in my life right now. And it doesn't mean if I'm not enjoying my present and being fully in it, I'm not ambitious or have a vision. I know where I want to go, but it's important. And I think COVID also pushed that to say, be present, be here, enjoy this moment, be fully immersed in it. It's still at the back of your mind that you want to be in the UN or at the WHO, but be here right now and enjoy this moment.
Fantastic.
So that's where I am.
Awesome. Dr. Nkuli, thank you so much for joining me. I really enjoyed this conversation, and your story is very powerful and inspiring. The resilience, the courage, you know, and all the best with what you're doing at the Nelson Mandela Children's Hospital.
Thank you.
I wish you all the best.
Thank you. And thanks for having me on your program.
Fantastic.
And you must visit the hospital.
Yeah, we had it. Well, friends, thank you so much for joining us. That's it for today. Please don't forget to subscribe, click like, and share with your friends and family. This is My Mentor, the place where ambitious, driven, and visionary leaders, professionals, and entrepreneurs gather. See you next time.